I want you to go back when Dr. Martinez was explaining that we have different types of leukemias, um, because the treatment might be very, very different one leukemia to the other, especially if we are talking about chronic or acute leukemias. So it depends on the type, the stage, and what clinical features that are present in the patient. Usually, with some chronic leukemias, we have to remember that since the patients are affected later in life, um, after 60, and this leukemia grows, let's say that so slowly, some patients do not require any treatment at all. It's also a very curious fact that the cells in the patients with chronic leukemia, they function better than the ones of an acute, because in acute processes, they divide so fast that they have a lot of defects. It's like trying to make copies and copies of paper. At the end, you will have copies of very bad quality. But when you do it chronically over a long time, when they give you time to do it, you might produce better copies. So that's why chronic patients with chronic leukemias do not have that many symptoms and can have treatments that are not necessarily so aggressive. Now, acute leukemias, of course, we do treat them with chemotherapy. Some go into remission, especially in chronic types. Some might need this more than once. They might go into remission for some years and then come back and need another sessions of chemotherapy. And for some leukemias, we might want to do a bone marrow transplant. Some patients that will require bone marrow transplant will first need chemotherapy to get rid of the abnormal cells, or as many as we can, before getting a transplant. Bone marrow transplants can be from yourself. That can happen. We might actually go into the bone marrow and then select the cells that we want and reproduce them and then put back to you when you finish chemotherapy. You can also have bone marrow from a donor different from yourself, which is very, very used nowadays. Other possible treatments are with medications that in a certain way can be considered chemotherapy also, or not. It depends on how your own definition of chemotherapy. Now we're not only for leukemias, but for other kinds of conditions, we are talking more and more about what we call the biologicals. Biologicals are what we call monoclonal antibodies. It's a complicated thing to explain, but to try to be simple about it, antibodies are molecules that basically are designed to identify and attach themselves to something. So now we are creating these antibodies to detect many different things. So if we want to fight a virus, then we might create an antibody that detects certain part of that virus and attach to that part, or to a bacteria or something in our own bodies. In this case, for example, one of many, because there are many of these drugs that are approved, rituximab, for example, identifies certain part of these cells, of these cancerous cells, and it attaches to the outside part, making it easier for our own body to identify those cells and kill them. That's how it works. So it's a very, very good medication. It's very strong and has some potential side effects, but definitely is one of the advances of medical technology and pharmaceuticals now in the present days. We also have some other medications which are being developed that they detect some other part in the cells and basically block a certain process that will eventually lead to the cancerous cell basically killing itself, what we call apoptosis, which is the own cell killing itself. So we have some other medications that will make the cancerous cells kill themselves. So it's very, very interesting. One of them is Gleevec, which is oral, not like rituximab, which needs to be infused. But Gleevec is oral, so it's a very, very useful medication.